I'm Dr. Rosenfeld. I'm a neurologist and sleep specialist currently in Savannah at South Coast Medical Group. And I've had a lot of experience with fibromyalgia. And what we're going to talk today about is one of my areas of interest and expertise, which is the connection between sleep and fibromyalgia. If you can, let's hold the questions to the end, and we can address those afterwards. We'll leave some time. I'll talk for about 40 minutes or so, and that should give us some time to speak at the end. I can't quite hear myself with this particular setup. If we can go back one slide, please. Thank you. So I think at the end what I'll do is I'll probably call in by phone so that we can hear everyone's questions. So in this first slide here, what we're looking at is the outline today. I'm going to tell you a little bit about sleep physiology, and then we're going to talk a little bit about the sleep disorders that are known and recognized in fibromyalgia. The big areas of interest are non-refreshing, non-restorative sleep, fatigue, restless legs, insomnia, obstructive sleep apnea, including upper airway resistance, narcolepsy, and sleep hygiene. We'll go over how we test sleep disorders as well as the various treatment strategies for each of these conditions. Next slide, please. Now this slide is the Canadian Clinical Working Case definition of fibromyalgia, and I included this because it shows an interesting paradigm shift in the way we think about fibromyalgia. Now typically fibromyalgia is referred to by the American College of Rheumatology criteria, and that is points 1 and 2 specifically. A history of widespread pain for at least 3 months involving pain in both sides of the body, above and below the belt line, as well as pain along the axial skeletal pain area. And then secondly, you have to have 11 of 18 very specific, anatomically specific tender points along the body. And that is the American College of Rheumatology criteria. However, the Canadian Clinical Case Working definition of fibromyalgia has broadened that to include a number of other symptoms and clinical signs, including neurological manifestations, cognitive issues, as well as you can see, fatigue, sleep dysfunction, autonomic and neuroendocrine manifestations, and stiffness. So, and this is a paradigm that's being used currently in a lot of research settings as well as some clinical settings as well. And what this shows us is that the Canadian Clinical Working Case definition is broader than the American definition, and it includes looking specifically for sleep and fatigue because of the known association in that area. Next slide, please. This is results that was extracted from a study by Dr. Bennett, which published in the Musculoskeletal Disorders a few years back. This was a survey of many thousands of individuals with fibromyalgia, and he rated the symptom complexes of various arenas. And what was somewhat stunning after we all saw the results was that pain, which of course is the hallmark condition of fibromyalgia and the only criteria that's used by the American College of Rheumatology, was not the first, second, or third most common complaint in patients with fibromyalgia. Morning stiffness, fatigue, and non-refreshing, non-restorative sleep were actually higher, and then you see some of the neurocognitive aspects like forgetfulness, commonly referred to as fibrofog within the fibro community, down there as well. So this shows us now with a statistically very high degree of certainty that that sleep and fatigue issues actually are more prevalent in fibromyalgia in terms of the complaint severity scale than pain is for the majority of patients. Next slide. The European League Against Rheumatism is a oversight group of rheumatologists, international group, that every few years comes together and looks at literature in a particular area and makes a consensus opinion about either testing or treatment. And a few years back, 2008, they looked at fibromyalgia. And what they showed is that they had a number of recommendations, but one here that I listed shows that optimal treatment requires a multidisciplinary approach with a combination of pharmacologic as well as non-pharmacologic modules tailored according to pain intensity, function, associated features such as depression, fatigue, as well as sleep disturbance. So we're even seeing groups like the European League Against Rheumatism stressing the point that fibromyalgia is much more than a pain condition, and for optimal therapy you need to look at other issues such as emotional, cognitive, and sleep. Thank you. Next slide. So this is a slide that I commonly use in my lectures that refers to how I'm currently looking at the pathophysiology of fibromyalgia. And what we see is that we have central pain augmentation in the bottom left, and that's what we understand is central to the pain generation in patients with fibromyalgia. We also have hormonal dysregulation, issues such as thyroid and adrenal issues, growth hormone deficiency, and a host of others. And up at the top, deep sleep deprivation. And that's what we're going to be talking about a little bit now. What happens is any of these issues tend to augment the other. And if you are sleep deprived, you're going to be stressed, you're going to be in more pain. However, if you're in pain, you're going to have worse sleep, you're going to be more stressed. And so these issues feed upon each other in a vicious kind of way and exacerbate the dysfunction of the others. Next slide. So this slide is a picture of what we look at when we do a sleep study. There are 4 stages of sleep. A lot of people think of REM sleep as the deep form of sleep, but this is actually incorrect. REM sleep stands for rapid eye movement sleep. That's when you're dreaming. And the brain waves during rapid eye movement sleep are identical to those of the awake state. There's generally considered to be 4 other stages of sleep. Stage 1 and 2 together are called light sleep. And there are some mixed frequencies, what are called the theta range frequencies. And then stage 3 and 4 underneath that are called deep sleep, or alternatively referred to as slow wave sleep. A lot of times now when we do a sleep study, that we'll just mark light sleep, deep sleep, and REM sleep. In REM sleep you have beta frequencies, which are very fast. And in stage 3 and 4, the deep sleep, you see these large waves. Those are called delta waves. Next slide, please. Now this slide shows what happens to patients with fibromyalgia. So in the last slide, we saw the different stages of sleep, what they look like when we look at the EEG, the electrophysiological aspects. Now when we put it all together in a typical 7 hours of sleep, you can see in the top what's called a hypnogram, which is the way we score sleep at night. You see you start off going from 1, 2, 3, 4, back down to 3, 2 REM, and then back down to 2, 3, 4, 3, 2 REM. And in the first 4 hours or so of sleep, you see that we're trying to get down into those deep stages, that stage 3 and stage 4, at least 2 or 3 times. And then at the end of the night, you see there's a much more heavy emphasis on getting your REM sleep. We oscillate between REM light, REM light. And that's what's considered to be a normal sleep architecture reflected in this hypnogram. In the picture below, you see, however, fibromyalgia. And in fibromyalgia, there's a lot more unexplained arousals where the person just spontaneously wakes up. Now, people with fibromyalgia will tell you this for a long time, that they wake up all the time, they hear every little thing. What also is interesting is that you do not see a lot of deep sleep, very, very little as a matter of fact. Some patients don't get any at all. So this is fairly characteristic of people with fibromyalgia. Lots of disruptions, lots of fractured sleep, and very little access to deep sleep. Now, this also could be a hypnogram of someone who is 70, 80, or 90 years old. And what's interesting is that the sleep patterns of those with fibromyalgia are very, very similar to the elderly or people usually many decades ahead of them. Next slide, please. Now, the slow-wave sleep dysfunction that has been commonly seen in fibromyalgia has been referred to alpha intrusions. And I didn't speak about this too much, but this is something that we're going to talk about now. Even if patients do get into that deep sleep or slow-wave sleep, it seems to be abnormal. The waves that we talked about are called the delta waves. Now, alpha waves are those waves that we see when we're awake. And it so happens that people with fibromyalgia, even though they are in that deep sleep, they actually have a superimposition of these alpha intrusions into their deep sleep. In a way, even though they're in technically deep sleep, it looks from an electrophysiological standpoint from their EEG that they're actually almost awake. So in a way, they're pulling an all-nighter. And again, they've been telling us this for a number of years, that they feel like they are awake, that they can hear every little thing, and this is actually quite easily to discern if you carefully analyze their sleep studies. And because deep sleep is so important for the refreshing aspect of sleep and health, it is believed that this deep sleep dysfunction can be certainly related to a lot of the complaints that patients with fibromyalgia relate to us. There are neurochemical and neuroimmunological aspects which are disrupted during sleep. Next slide. The first person to actually first describe this was Dr. Harvey Moldavsky, who's largely considered to be the father of the science of fibromyalgia. This article came out in 1975, and he described musculoskeletal symptoms and non-REM sleep disturbance in patients with fibrositis. In 1975, fibromyalgia was described as fibrositis. It was renamed fibromyalgia in 1976. And what he showed is that in deep sleep, or non-REM sleep, there was these alpha intrusions. He was so convinced that this deep sleep dysfunction was the cause of fibromyalgia that he actually took college students the following year in the study, the second study, and deprived them just of deep sleep by ringing a bell. So the patients were not aware that their sleep was being disrupted. They still had plenty of light sleep and REM sleep. But after a few days, these college students all developed musculoskeletal pain and cognitive impairment. In other words, he basically induced a fibromyalgia-like syndrome by selectively depriving them of deep sleep. Next slide, please. So this alpha wave intrusion is very commonly seen in people with fibromyalgia. In my experience, I see this in over 90% of people I study in my sleep lab. Again, alpha waves are really present in patients when they are awake. But in people with fibromyalgia, we typically see them all night long. And it's this feeling that patients are not getting refreshing sleep and they're fatigued, which we believe can be very easily correlated with this alpha intrusion phenomenon. Sometimes this is also referred to as alpha delta sleep. Next slide. So in this slide, we can see a 30-second epoch of a sleep hypnogram. So when you get a sleep study, we're looking at your brain waves. Those are the first 4 leads up top. Then we look at your eye leads. That's how we can tell if you're in REM sleep. That's rapid eye movement sleep. Then we have an EKG looking at your heart rate. We have monitors on your legs looking at your snoring, looking at your airflow. So there's a lot of things that we're looking at when we do a sleep study. Well, let's go back just for a second there. And so what we can see is if we look up top in the EEG leads, we can see this deep, low waves called the delta waves. Now, if we go to the next slide, we can see fibromyalgia. And we can obviously see that this looks dramatically different. What's interesting, however, is that according to the currently accepted criteria for scoring sleep studies,